Hello. Thank you very much for that introduction, and thank you everybody for joining us for this webcast. This is Khalid here, and I will start off giving the first part of going over the first part of the presentation, and then Luke will continue with the second half. Just as a bit of background, the intention today was to cover some of the material that's appearing in the O'Reilly book, Anonymizing Health Data, which appears on your screen as well on the left side. So really this book describes the methodology and goes through a number of case studies and examples of anonymizing health data based on the some of the products that we have been involved in. So a lot of the technical details for those who are interested would be available in that book, and the early release is accessible through the O'Reilly website. So there are three parts. Then there's the introduction to methodology, which I will cover. I think after that we will take just a bit of a pause and take questions, and then Luke will continue with part two, and then I will close off at the end, and then we'll have another Q&A session. So that's the layout of the session for today. So I'll start off with the introduction and the methodology. So the first question is whether to, sorry, we're just having a little bit of a technical issue with the slides refreshing. Just bear with us for a second, we'll try to fix it. But anyway, I'll continue talking as this goes on. So the first question is whether to anonymize data or not to anonymize data. Normally, when you're sharing data for secondary purposes, under most privacy laws in most jurisdictions, you can really do that under two contexts. One is if you obtain consent from the patients themselves, or the second way is if you are able to anonymize the data. In practice, obtaining consent is challenging, especially when you have very large databases. It can be costly. It may be hard to contact the patients. And also there's evidence of consent bias in the sense that consenters and non-consenters differ on important characteristics. So there's a compelling reason from that perspective to anonymize the data, because it's one of the methods that are permitted in legislation and regulations in most jurisdictions to share health information. There are a couple of other reasons why you would want to anonymize. The other one is there is the cost of breaches. So in most jurisdictions there are breach notification laws. In the U.S., most states have breach notification laws, and there's a federal breach notification law which requires a data custodian to inform the affected patients, as well as the regulators, and in some cases the media, whenever there's a breach. And the cost of dealing with a breach notification can be quite high. And of course, if the data is anonymized, then you don't have to notify. So you essentially eschew all of these costs, and the return on investment from avoiding these costs can be quite substantial. You make an investment anonymizing, and then you avoid these subsequent costs. Another important thing to note is that not all healthcare providers are willing to share health information, even if they're permitted to. And we've encountered this in a number of contexts. For example, family doctors are not always willing to share health information even for public health purposes because of concerns around privacy. And we've seen that also in surveillance, syndromic surveillance contexts, where data has been collected from emergency departments, and hospitals are unwilling or reluctant to share health information even if they are permitted to through legislation, unless the data is anonymized. So it essentially facilitates the buy-in from providers. Anonymization facilitates the buy-in from providers. And as I mentioned, there's a compelling financial case in a sense that you avoid the breach notification costs. One of the best available estimates today is $200 per patient to deal with a breach. So if you have 1,000 records in a database that is lost or is affected by a data breach, then your cost is essentially $200,000. So you can imagine for large databases when there's a breach, the cost can be quite significant. The other thing to note is that patients have exhibited privacy protective behaviors where if they have concerns about an organization's capacity to protect their personal information, they tend to not seek care, lie to their doctors in terms of their medical history, seeing multiple providers, so no single provider has all the information about them, and self-treating and self-medicating, and these types of behaviors, of course, are not desirable, but they also result in quite significant distortions to the data, and large percentages of the general public and patients have admitted to these kinds of behaviors. So anonymization is a way to assure the public and patients that any kind of data sharing that's occurring is done in a responsible way. So really, when we talk about anonymization, there are two sets of techniques that we consider. They're masking and de-identification. And they're very different ways or techniques under both of those headings. So with masking, we're dealing with things like first name, last name, social security number. These are called direct identifiers, and they are pieces of information that can directly identify patients, their address, their email address, their social security number, medical record number, and so on. Most masking techniques result in a significant distortion to the data, so you cannot do any analytics on the data afterwards. So these types of techniques include things like randomizing the data, removing the data, creating pseudonyms, etc. So really, you apply masking in situations where there is no intention to perform any type of analytics. So creating pseudonyms is one example. You essentially take a variable and you maybe encrypt it or hash it would be one way to create a pseudonym, and then use that as a way to still link records in the database, but without the original value. So usually social security numbers or some other kind of unique identifier is converted to a pseudonym, but then you can't do any analytics on the pseudonym, right? And of course, removing a whole field is another way that you would apply masking. And of course, if you remove a whole field from a data set, then there's really no easy way to there's no way to perform analysis on that field. And then there's randomization, where you replace values with random values. So you take the first names and replace them with random first names from a database, and last names random last names. You have facility locations or facility names. You replace them with random values, etc. So this is what we call randomization in the context of masking. Again, you can't perform any analytics on that type of randomized data. So you apply masking to direct identifiers, and this is necessary. It's an important thing to do in your data set. Not all data sets have direct identifiers. For example, in a lot of cases where data is being used for research, direct identifiers are just removed completely. But in some cases, such as software testing, releasing data set or sharing data set for the purposes of training or doing demos for sales staff on a software application, you want to keep all the fields in the database. You cannot just remove fields from the database, so then you use randomization and pseudonymization. So there are other cases then where you will want to do analysis on the data. And the important types of fields there are things like age, sex, race, postal code, zip code, for example, income information, so any kind of demographic information, socioeconomic status information, location information, all kinds of dates. These are fields that are useful for analysis, but they're also fields that can re-identify individuals. So there's a whole set of techniques called de-identification techniques that are used to protect that data. And we'll focus today mostly on these de-identification techniques. And an important characteristics of the de-identification techniques is you want to minimize the distortion to the data, because the objective is to perform analytics on that data set afterwards. So one example of a standard for de-identifying data is the safe harbor standard in the HIPAA privacy rule, and that's in the U.S. And I'll talk a little bit about that momentarily. But it's a commonly used standard. It has some strengths and weaknesses, but essentially says there are 18 variables. If you remove them from your data set, then your data set is considered de-identified. So the HIPAA safe harbor also has a requirement that's called actual knowledge, and this is an important requirement in safe harbor, and it's important not to forget that. So in addition to removing the 18 variables, you must also demonstrate that there's no information in the data set alone or in combination that could identify an individual. So it's not just removing the 18 variables, it's also you have to demonstrate that you do not have actual knowledge that an individual can be re-identified. This actual knowledge has to be specific to your data set, not theoretical knowledge. And as an example, if you have a data set where there's an occupation field and the occupation is the mayor of the city or the president of the country, then that immediately re-identifies the individual because there's only one person with that occupation. So just something to remember when thinking about the HIPAA safe harbor standard, that it's not just removing 18 elements, there's this actual knowledge requirement that must also be satisfied. So safe harbor is one standard for de-identifying data. We also see organizations developing their own heuristics or rules of thumb to identify the data. Usually these rules of thumbs have evolved over time. For example, we shall not release data about areas with less than 50,000 people living in them, or where the population is less than 500, or there are many rules of thumb that have been developed, and these sometimes are strongly justified, sometimes they are not, and so we refer to these as heuristics. And then there's the statistical method that's also described in HIPAA under the HIPAA privacy rule, and this is the one we're really going to focus on and describe because it allows us to take into account the context of the data release. So heuristics in the safe harbor don't take into account the context. You have a set of rules that you generally apply across the board to all data sets, and of course that has pros and cons. Some of the pros are it's very simple. Some of the cons is that sometimes you may release data that has a high risk of identification, and sometimes you may remove too much information from the data set that you don't have to. So we're going to focus on the statistical method under HIPAA kind of as our framework for de-identification, and essentially all the case studies are based on that. So let's talk a little bit about some of the de-identification myths as well that we sometimes hear. So myth number one is that it's possible to re-identify most, if not all, data, and we hear that often. So there have been a number of well-publicized case studies and examples of data sets that were re-identified. It just happens that all of these examples, well, actually the vast majority of these examples were done on data sets that were not de-identified. And we did a review of all publicly known re-identification attacks up until the end of October 2010. There were 14 that we found that were true re-identification attacks. 6 of them were on health data. And 12 of the 14 were done on data sets that were not de-identified using any of the standards that I mentioned. They didn't use the HIPAA safe harbor. They didn't use the statistical method under HIPAA. Well, actually, they didn't use any defensible heuristic either. That's kind of based on any of the contemporary standards. So I think that myth is only true if you don't de-identify the data properly. In cases where data sets have been de-identified properly, it's not impossible, but it's very hard to re-identify the individual in that data. So there's really a strong case to be made for using standards and using best practices to de-identify. You can't just improvise, because what we've seen is improvised methods are relatively easy to reverse engineer and result in successful re-identification attacks. And you must also keep in mind that there's a whole discipline that has emerged around re-identification attacks, and there's now actually a code of conduct for professionals who do re-identification attacks. So there's a risk there that if the data is not identified properly, individuals will come and try to re-identify the data set. The other important myth that we wanted to cover is around genomic data. And so there's a general belief that genomic sequences are not either are not identifiable or are easy to re-identify. So the fact is that sequence data is hard to de-identify, and the risk of identification from genomic data under certain conditions can be quite high. But these certain conditions are important. The context is important. And as a general statement, it's hard to protect genomic data today. So usually when that data is shared, by large data custodians, they have some various access control methods. So there's a whole set of attempts to come up with ways to de-identify data, genomic data, but I think this is a work in progress. Right? There are no well-established techniques. So the things we're going to talk about today apply to survey, administrative, and clinical data. They will probably not work very well for they will not work very well for genomic data if you try to apply those techniques to genomic data. So we kind of exclude genomic data from our discussion today because they're quite hard to de-identify. So now we're going to describe a risk-based de-identification methodology that follows the HIPAA statistical standard, and this is consistent with the way the identifiability is addressed in privacy laws, I think, in most jurisdictions that we have seen. So the first principle from this de-identification methodology is that the risk of identification can be quantified. There are very good metrics that have been developed and good estimators that have been developed to quantitatively evaluate identification risk. They make assumptions, as most statistics do, but these are reasonable assumptions. It's possible to do a thorough risk assessment and evaluate these assumptions and then use that as a basis for measuring the risk. So that's one thing to keep in mind. Then the second important thing to keep in mind is that sorry, we are actually in a healthcare facility, and there's a pager that just went off, so public announcements. It's gone now, thankfully. Okay, so the Goldilocks principle is important as well. When you de-identify data, there's distortion that occurs to the data. So part of the process of de-identification is to balance data utility and data privacy. So we call this the Goldilocks principle because you want to get it just right. Just enough de-identification to protect privacy, but still retain sufficient utility in the data so that you can do analytics on it afterwards. So this is the graph is the graph that you see right now shows this trade-off of this balance between privacy and data utility. That as if you want maximum privacy, then you'll have zero data utility, and if you want maximum data utility, then you'll have very little privacy. And ideally, you want a point in the middle. So this is the trade-off, and this is what the identification methods try to do. Kind of essentially try to find a balance in the middle along that line. And the top right-hand corner is the ideal, which of course is where you have maximum utility and maximum privacy. The quality of your de-identification methods will determine how close you get to that top right-hand corner. The other important thing is that the re-identification risk needs to be very small. The term very small is actually the term used in HIPAA and the HIPAA privacy rule statistical method, and it's not defined. So when you operationalize this, you have to determine what very small means, which basically operationalize that term, which means you have to figure out how to measure the risk and how to determine thresholds on that risk metric. And then another very important consideration or thing to keep in mind is that de-identification is not only a set of technical transformations you apply to your data. It's a set of other technical transformations as well as other mitigating controls, which include practices you need to have in place within the organization that is receiving the data. So it's not just a technical thing, it's technical plus controls that need to be put in place. And we'll talk a little bit about some of these controls later on. Okay, so our methodology then has 5 steps, and I'll go through these quickly, just to give you an idea of how this works. And by the way, this methodology is consistent with existing standards. So if I'll just mention a couple of those quickly, that's a great standard that was published by the UK Information Commissioner's Office, kind of a code of practice for anonymization. Health and Human Services in the US has published a good guide for implementing the identification standards there. And then there's a Canadian standard that was developed by 2 federal agencies around the identification of health data. And all these standards or guidelines, best practices, etc., are consistent in that they talk about measuring risk, they talk about taking into account the context of the identification, and talk about the need to balance technical modifications to the data, transformations in the data with other controls that can be used to manage the risk. So it's perceived as a risk management exercise. Okay, so step 1, as I mentioned before, you have to select your direct and indirect identifiers in your data set. In practice, this is doable with a high level of confidence. So direct identifiers are masked, and indirect identifiers are the ones that you would de-identify. And an important distinction is you really want to, direct identifiers are the variables you really want to do analytics on, and direct identifiers are the ones you don't care about doing analytics on. You just want to protect the identity of the individuals. So their direct identifiers are things like name, telephone number, health card number, etc. Indirect identifiers are, or sometimes they're also called quasi-identifiers, and they're things like demographics, location, all dates, event dates, birth dates, death dates, etc., socioeconomic status, and medical codes as well. So procedure codes, diagnosis codes, sometimes they're rare diagnoses or rare procedures, and these may have an impact on identifiability. So the next important thing is, of course, to determine what the appropriate threshold is. So I mentioned before that you have to ensure that the risk is very small. How do you operationalize very small? And so we did and this is one of the things that sometimes causes confusion. So we did a review of the literature, and over the last 20 years, people have been releasing data. They didn't just start releasing data recently. So there's a lot of precedent. Precedents come from court orders, court judgments, regulator orders, professional association guidelines for releasing data, health data, justice data, education data, census data. And in general, the risk thresholds they have used vary between, as you see here on the slide, between 0.23 and 0.05. These are essentially probabilities of re-identification. There are a number of different metrics that one can use. Luke will mention those later on, maximum risk, average risk. But in general, there's a range of risk thresholds that have been used to release data. So the CDC releases some data using a 0.33 threshold, and CMS releases claims data, Medicare and Medicaid claims data publicly using a 0.09 threshold. But in reality, these are the thresholds that have been used in practice to release health data, right? There are strong precedents for this, and this is an acceptable risk that we as a society have agreed to take in order to facilitate the sharing of data. Again, these are strong precedents and have been in place for a number of years. And so they serve as a good launching point for deciding what is very small risk. Okay, so by using these precedents, then we can justify the thresholds within that range, between 0.3 to 0.05 range. One of the criteria, of course, is whether the data is going to be posted publicly or not. Public release is very different from private release, where you're going to make data available to a known entity. And one way to determine the threshold, so here we describe a range. One way to determine the threshold, the exact threshold that you will use within this range, is what we call the invasion of privacy test. So you look at the sensitivity of the data, potential harm to the patient, so there's a re-identification, and the consent mechanism that was in place or may not have been in place when the data was released. So they're very well-defined criteria. We call them the invasion of privacy for deciding what the appropriate threshold should be within that range. And then if the measured risk is above that threshold, it's considered identifiable information. If the measured risk is below that threshold, it's considered de-identified information. And there's a checklist that is available to allow you to basically specify these invasion of privacy criteria quite precisely. Then the next step, step number 3, is to examine plausible attacks on the data. So it depends whether it's a public data set or a private data set. So if it's a private data set, which means it's non-public and you're releasing it to an entity that is known, we really look at 3 different types of attacks. The first is whether the data recipient is going to deliberately attempt to re-identify the data. So let's say I'm giving a data set to a company. Let's call the company Kronk Pharma for the sake of an example. So Kronk is going to get the data. Are they going to deliberately attempt to re-identify the data set? We look at a number of things, whether you have a contract with them, whether it's security and privacy controls that they have in place. So this is what I meant before when I talk about context. It's always context dependent. If contract has lousy practices in place, that's high risk. You're going to de-identify the data more. If Kronk has very good practices in place, then this is low risk and you can de-identify the data less. So these are factors that need to be taken into account. Then the other thing to think about is whether the recipient is going to potentially inadvertently re-identify the data. So when you give data to a statistician or a data analyst, they may recognize someone they know. And so this is called an inadvertent re-identification, and it's possible to quantify this as well. And this is all described in the book, how to do that. But it's possible to quantify what's the probability of an analyst recognizing someone they know in the data set. And quantify it under reasonable assumptions. And then the last type of attack that we consider for a non-public release is a breach. So what's the probability of the Kronk having a data breach? So you can use an average across the kind of healthcare providers, and there are good surveys out there that have provided defensible numbers around the probability of a breach occurring, or you can consider the security and privacy practices of Kronk to determine what's the likelihood of them having a breach. So by looking at deliberate, inadvertent disclosures and breaches, you essentially cover the universe of things you really need to consider. Is they going to deliberately attempt to re-identify? Is the re-identification going to happen accidentally? And what's the probability of a breach occurring? So these factors can be considered, quantified, and used as part of the risk assessment to determine whether your measured risk is above or below that threshold. And then if the data is going to be released publicly, really there's only one thing you need to worry about, which is a demonstration attack. So a demonstration attack is when someone deliberately tries to re-identify individuals in your data set. And a demonstration attack is has some special characteristics. One is that the adversary only needs to re-identify a single individual in order to make the point. You just want to demonstrate that the re-identification can happen. So you really want to protect, you're not going to look at the average risk. You're going to want to make a worst case assumption and protect every single individual in that data set under worst case assumptions. And also, of course, a demonstration attack is usually, it needs to be publicized. So in individuals who do demonstration attacks are not going to do anything that's a breach of contract or that's not legal. So, and it just happens to be that demonstration attacks will have the highest quantitative risk. So for public data releases, it's really just demonstration attacks that you want to care about, because if you take care of risks from demonstration attacks, you'll manage the risks from other types of attacks. Then the fourth step, this is where you actually de-identify the data. So what I've described so far is the kind of the methodology risk assessment piece, where you determine which variables you're going to look at, which ones you're going to mask, which ones you're going to de-identify. You determine what metrics you're going to use, maximum risk or average risk, determine what the threshold is going to be by looking at this invasion of privacy, and then looking at the types of attacks you need to consider. And for each type of attack, there may be some other assessments that need to be done and other checklists that need to be considered. So step 4 is to then de-identify the data. So there are a number of techniques that can be used for de-identification. Generalization is one of them, which essentially means you reduce the precision of a data field. For example, you convert the date to a month or a year. There are various randomization techniques that you can overlay on top of generalization. And again, these are described in more detail in the book. The second technique you can use is suppression. So you would remove individual values or cells in your data set because they make individuals stand out, make them unique in your data set or in the population. So a good example, we do a lot of work with the birth registry, and a 55-year-old mother would be unique because there's usually only one in the province, for example, every year. And then the other kind of technique you can use is subsampling. Essentially select a random sample of your data set. It's a very powerful approach for reducing re-identification risk. Again, the impact of subsampling can be quantified, and it's usually most effective for non-public data releases. Quantitatively, it's not very effective for public data releases. But for non-public ones, subsampling can be a powerful way to reduce the risk of re-identification. So these are the three main techniques that work well, produce data sets that are generally accepted by the data analysts because they understand the modifications that were done. And they also produce data sets that can have quite high data utility. The last step is to document the process. This is really important from a regulatory perspective. In case there's an audit or investigation, it's necessary to demonstrate that all the considerations that I spoke about have been considered. So you need a methodology to describe what methodology was used and whether it was a defensible methodology, then to document the results. Again, I must emphasize the importance of documentation because this is a regulatory play. You can't just make that stuff up, because if there's a breach, you can avoid a lot of pain if the identification was done properly and was defensible. Okay, so just remember, you can't make this stuff up. You have to use existing standards that are defensible, and you have to document it in case there's a breach, there's an investigation or an audit or a complaint, depending on your jurisdiction, of course. So in terms of measuring risk under plausible attacks, we have the ones that I mentioned before. Deliberate attempt is, and let's go back to our example of Kronk. So you measure what's the probability of a re-identification occurring given that an attempt has been made to re-identify the data set. So probability of attempt can be evaluated using a subjective evaluation scheme, but it considers, uses checklists and so on, considers security and privacy practices that the organization has in place. It looks at whether they have signed a contract, whether certain clauses exist in the contract prohibiting re-identification or not. So there are subjective ways to evaluate probability of an attempt that are defensible. They have very strong face validity. And then the probability of re-identification given an attempt is what you measure from the data. You multiply these two, and you get the overall probability of re-identification given that an adversary, given that Kronk will attempt to deliberately re-identify the data. And there are two things to consider. One, of course, is as a corporate entity, Kronk will re-identify, and the second is there's a rogue employee in the organization. The second type of attack that we consider is this inadvertent re-identification, where an analyst notices someone they know, so you take into account the prevalence of the disease and how many friends that a person would have. So we know based on the Dunbar number that on average people have 150 friends. Using that kind of information, you can estimate the probability of a statistician or analyst knowing someone with that disease and coming up with a probability of the statistician having an acquaintance in the data set. So that can be quantified, and then probability of identification of an individual given that they know someone in the data set, which is the second term in that T2 equation, is measured from the data set. And then T3, which is a breach, there's data on the probability of a breach occurring in a healthcare organization based on various surveys. So probability of breach can be quantified, and again, probability of re-identification given that a breach occurs can be measured from the data. So the three attacks that I mentioned on a non-public data set can be quantified in a defensible way. T4, which is the public data, there is no context here. You just make the worst case assumption and you assume that the demonstration is going to, attack is going to occur, and that's the probability of attempt is 1, and that it will happen. So I'm going to actually move quickly through the next set of slides so that we can go to the case studies. There is as I mentioned before, they're choosing the thresholds. There are many precedents for that. They're based on court orders and recommendations by regulators, for a lot of the precedents are based on maximum risk. So there's a reasoning process to make it apply to non-public data, which I will have to skip. So let me speed us up to part 2, and I'll pass it on to Luke. Did you want to pause for some questions?
Yeah, I think we had them.
Okay, so why don't if there are any questions thus far, then maybe we can take a couple, and then we'll start part 2.
Yes, we actually do have a few questions here. Chip would like to know, where did the breach cost metric come from? I'd like to reference it, but want to attribute it appropriately.
Yeah, it's actually a series of studies by the Poneman Institute. So they've been doing this for a few years. It fluctuates. Sometimes it's a bit over, less than 200. Sometimes it's up to 300 for health data specifically. It's U.S.-centric data, but they have done international surveys as well for some of the years where they've collected data from the UK and I believe Australia. But anyway, Poneman Institute. You find the reports there.
And Matt is interested in knowing how to anonymize geolocation data in small communities like 200 to 800 people where everyone knows most everyone.
Okay, so the traditional way to anonymize the spatial information is to crop. So, okay, so what is geospatial information? Maybe we'll start there. We're talking about zip codes and postal codes, not individual addresses. If you have it in someone's individual addresses, you can geocode the exact longitude and latitude for their house, and that's a bit of a challenge to anonymize. So we're talking about zip codes and postal codes. Traditional ways to crop these, so you essentially truncate let's say the zip code, truncate the last two digits from a zip 5, so you end up only with the first 3 digits of the zip code. That generally results in a lot of data utility loss, where you end up with very large areas, and the data becomes less useful for geospatial analysis. So a better way to do it is to cluster adjacent areas. So you do some geospatial clustering on adjacent areas in your data set, and that way you get tighter and smaller clusters and smaller areas, and then you replace the zip code with a zip code from that cluster. So essentially shifting the zip code to an adjacent zip code, but the shift is proportionate to the re-identification risk. And so that works because it results in minimal shift. It's still a shift of your zip code, but it's a minimal shift that still can provide guarantees that your identification risk is small. So that's typically how we've dealt with small areas. And it works reasonably well in practice. When we did some, for example, hotspot detection for, the hotspot for outbreaks, for outbreak detection and so on, the results from this type of clustered data have been quite similar to the hotspots detected using the original data. So for some typical analyses that are done on this type of data, the results are quite similar to the original location data.
All right, and Brent would like to know if you could comment on small or large ferrous storing, like masked data of white collecting drug trial testing. And does the government allow this as an option? If not, what is the CF, please? So
I'll just give you my interpretation of the question, that it's around the collection of unique identifiers for patients in clinical trials or clinical studies. So that's generally considered to be a unique identifier, and it would have to be treated the same way, masked basically the same way we mask direct identifiers in a data set. The de-identification of clinical trial data would otherwise, not the unique identifiers, but the rest of the data would be treated exactly the same way as I described. You'd measure the risk, you'd take into account the context, and then you would apply controls or anonymization, modifications of the data to ensure that the risk of identification is acceptably small. Okay, so I think we'll pause here for a second. I'll let Luke now continue with part 2.
Thank you, Khaled. So for part 2, we're going to look at some case studies, because that's really where you start to understand things, when you can actually see them in context. Now we start with the simplest type of data set, which is cross-sectional data. In this case, we're going to look at a research registry. Apparently the slides are not updating for some reason. The first one that we worked with was Born of Ontario. This is an organization that we work very closely with. They basically collect the births in Ontario, and that, as you can imagine, that takes up a lot of data. We end up with 140,000 births per year in their data set. Now, so in this case, what we mean by cross-sectional, in case you're not familiar with the terms, is that you can't actually follow the same mother over time. What you have is, in each row, is you have a birth, and that birth may have, and in in the column, for example, you'll have something, a variable indicating how many children this mother has had in the past, but you can't link any previous births in the data. It's just It's just a bunch of rows, and those rows represent the births in Ontario. Now, in the book, we describe the process of getting de-identified data from a research registry. For example, we have a flow chart in there to kind of describe and the best practices you would have in a data access committee, but we're not going to go into that here. We'll just move on to actually look at some data instead. But if you're interested in that process and how it works, then we would recommend going, obviously, to the book and look at more of that process. But we're going to go into the data itself. We want to know how this works. So now let's imagine that we have a researcher. We're going to call him Ronnie. And researcher Ronnie really wants data. The first thing he tells us is, hey, I'm a researcher. Give me some data. Of course, it's not that simple. There is risk to consider. We can't just give data out because we trust someone. We have to measure the risk and determine what is appropriate. Now let's take a very simple data set. We'll look at just 4 variables, the baby's sex, the date of birth of the child and of the mother, and a postal code. So it's a very simple data set. But Bourne's been doing this for a while. They have a lot of data, and in this case, we have about 6 years' worth of data that is being requested, and that's about 1 million records. So it's a fairly large amount of data. The first thing we want to do, though, is we want to figure out, okay, how can we generalize the data? How can we make it less risky? For example, the obvious one is the date. So you don't want to give out a date of birth necessarily, unless it's the risk says you can. But it's unlikely you're going to give out the exact date of birth. So maybe you'll look at giving out the week and year of the date of birth, or the month year, or the quarter year. It really depends on how much risk you determine you can give out or allow. Another one would be the postal codes. Cal had already mentioned cropping. That's something as well we can look at. So what we do is we create a hierarchy for how we want to generalize the data and how we will consider generalizing the data. And then we have to set a threshold, of course. So we're looking at our overall risk. In this case, researcher Ronnie fills out a questionnaire. We look at the data that he wants and also various questionnaires to determine what we can allow. And in this case, we determined, well, 0.1 is good enough for researcher Ronnie. Now, if you were requesting specifically sensitive variables, congenital anomalies, mental health problems, then the risk threshold would have to be a lot lower. In this case, as we saw, it was date of birth, postal code, and baby sex. Not too much, so we're fine with that. We're going to let that one go. Now we go on to measuring the risk. This is sort of the meat of what we want to talk about. So how do we do that? Now, the first thing we're going to look at is our first attack that Cal had presented, which is a deliberate attempt. The researcher gets the data and actually wants to find someone in the data, even though they're not supposed to. Well, we think that's unlikely. Researcher Ronnie is a researcher at a health institution. He has very little motive or capacity, really. He doesn't have the resources to launch a full-scale attack of any kind. So we consider that based on these questionnaires that he filled out, we figure that, you know what, he's okay, that's fine. Then we look at, well, what sort of controls does he have to actually have the data? Is it computer encrypted, these sorts of things? And again, in this case, we say, well, researcher Ronnie, not so much. He doesn't have too much in the way of controls. So based on those questionnaires, based on the low motives and capacity, the low mitigating controls, we decide on a threshold of 0.4 for the probability that he will attempt. That may seem high, but that's in part because of the low mitigating controls. And this is all operationalized. It's not something that we just pick out of thin air. We have questionnaires they fill out, and so it's always standardized. It's always the same thing. So then we have to look at our next attack, which was oh boy, I know someone in this data set. This is the inadvertent attempt. It's an accident. You're looking at the data, and you see someone that has, 9 children in the data set, and they just had another birth, and you happen to know someone that has 9 children that just had another birth, and that's pretty rare. So that's what we're going to look at next. In this case, what we do is we look at the data set every year, and we determine what is the probability, what is the prevalence of births. And obviously, it's going to be pretty high. A lot of women in Ontario. And in this case, it's 0.027, which may not seem too bad. But then when you actually calculate the probability of knowing someone in the data, which is what the next equation that pops up, what you'll see, it's actually pretty high. It's almost 0.9. There's like a 90% chance that you're going to know someone that's had a birth. And that makes a lot of sense, really, when you think about it, because who doesn't know someone who's had a birth? Women, of course. Now, the equation itself, I'll just briefly say that the equation there, it's a standard equation, nothing too fancy there, except for the number at the top, which is 150 over 2. That's what's called the Dunbar number, the number of people you know, your basic network of friends. There's a lot of research on this, and the basic number is 150. And we divide that by 2 because, well, there's obviously just women that we're considering in this case. So then after that, we look at the third attack, which is a data breach. So somehow the data has been lost. There's been a USB lost, a USB key with the data on it that's been lost or something like that. Now, Cal had mentioned briefly that there's some historical data, and he gave a reference. And so in this case, the actual value is 0.27. That's the probability that you will have a breach. Now, out of all those three attacks, there's actually one more I should mention, which is the public data, but we don't have to worry about that in this case because, well, we're not worrying about public data, of course. This is a researcher that we know is getting the data. So we're not putting the data up on a website or something. So then we go back and we look at our probability of a re-identification and an attempt and an inadvertent attempt, etc. And we look at that overall equation and we say, okay, we have to keep the risk has to be below 0.1 overall. And that's what you're seeing here. So the T here is just the different types of attacks we're looking at. In this case, 1, 2, and 3, the three different attacks. Now, we have to consider all of them, of course, but the one that was the highest, the one that's going to cause us the most problem, in a sense, is the inadvertent attempt. The, oops, I know someone in this data. I have to deal with that. So really, we're only going to have to deal with that one because it's the one with the highest amount of risk. Now, once we have that, we've figured out which one we really want to manage, then we can move on to de-identifying the data. Now, we're going to go on a bit of an aside here because we got to consider one technique. This isn't the one we necessarily use. It's just a starting point to explain how you de-identify a data set. And it's called K-anonymity. Now, the idea here is pretty simple. What it is you want to make sure you have K people in a data set that look the same, basically. So what you're going to see pop up is a data set that has just three fields, admission date, gender, and age. And what we want is K people, in this case 3, we're doing 3 anonymity, 3 people that have the exact same values across those fields. So 3 people with the same admission date, the same gender, and the same age. And you'll notice it's already been grouped. There's been a little bit of suppression involved. So we've cleaned up that data so that now everyone is 3 anonymous. There's at least 3 people represented in each row. So when you look at it, you can't tell which one is, let's say, Bob. You can't tell because there's 3 people that look exactly the same. So that's just to give you a bit of an idea. That's just one technique. K-anonymity has its pros and cons, but it's one that is a good starting point, let's say. So next we then apply this to our data that we were talking about for researcher Ronnie, and we say, hey, Ronnie, we've got some data for you. And our first pass, we came up with date of birth of the mother in 1 year, so 36, or I guess in this case date of birth, so let's say 1976, for example. The date of birth of the baby in this case is week year, and the postal code, well, we didn't think Ronnie really needed the geospatial information, so we just said, okay, just one character. But as often happens in this, the researcher comes back and says, oh, no, I actually need a lot more. I need more precision on the geographic information. So then you go back to that person and you say, okay, fine, you rerun your risk analysis and you change parameters, which is what you're going to see here. Now, the bottom, I'll mention on the bottom, the table there, it's just to show you also the amount of suppression that occurred. It's pretty low until we have to give out slightly more or less generalized, let's say, variables. Now, the next question we often get is, well, what if we want to apply the exact same de-identification the following year? So researcher Ronnie comes to us and says, I only want 1 year of data. And then the following year, he says, you know what, I deleted the past one like all the things that I had to, but I want to do a follow-up study. And then he comes back a year after and he says, I want another follow-up study. And that's fine. The question is, can we then apply that same de-identification we did in the first year to the following year? So the same generalization, assuming the same risks, and then we just run it through our machinery and say, has this worked? Can we do this year on year? So what we did was we took the born data that we had. Instead of doing that big one chunk of 1 million records, we broke it up. We said, let's look at 1 year at a time. We'll look at 2005, 2006, 2007, so forth, and just apply, do our risk metrics, set up the generalization, and see, based on that data, can we apply it over and over again? What happens? What happens if we apply the same generalization? Do we end up with vastly different things? And as it happens, we don't. What we find is that the missingness, the amount of suppression that we've applied is pretty much the same. The entropy in the data is pretty much the same year on year, and that's good news. However, there are some caveats. The born data, it's births. Births don't change pretty much in Ontario. I mean, it's pretty much the same population, so there's no major reasons to think that anything's going to change on that over that period of time. So really what you want to do is you want to look at this, though, every, let's say, 18 to 24 months. Because even though you can apply it over and over again, you should check, because you never know if things might change. So that's something to consider. Also, if you were to add a variable, let's say researcher Ronnie in the follow-up year decides, you know what, I need an extra variable. I need to know about the mother's other children, like how many births have they had already, then that completely changes the ballgame. You have to restart. You're going to have to redo your risk assessment in that case. So now we've done the cross-sectional data. We're going to spend another 10 minutes on longitudinal data to give you an idea of how these concepts now would grow into a more complicated data set. So what we're going to look at specifically, whoa, I don't know why this just jumped forward for some reason. I'm going to back up a little bit here. Okay, yes, okay. So longitudinal data, we're going to look at a state inpatient database. I'll discuss that a little bit more later. But the idea here in longitudinal data is that now you can track a person over time. You're looking at multiple records for the same person. And as I just said, you're going to have to do this differently. The cross-sectional methods we saw are a starting point, but they're not going to apply directly, and we'll see an example of that. So the question then is, since we've already talked about k-anonymity, well, can we apply that same k-anonymity? Can we do that again? So what you're going to see pop up on the screen shortly is two data sets. They're actually from the same patients. They're going to have the same patient ID, but one is going to be on the left-hand side. You're going to see what we call level 1 data. So this is the data that doesn't change over time. You've got date of birth and gender. We don't expect these to change over time. On the right-hand side, what you have are the things that do change over time. This is more the longitudinal component of the data, the level 2 data. So you have the visit date, person had multiple visits. You have postal codes that have changed. This could be their home address, for example, which obviously people can move. And then what we do is we combine these together. So we're going to flatten them. Well, actually, we're going to flatten them later. But first, we're going to combine just the level 1 with level 2. So you're going to see the date of birth is going to be repeated, and the gender is going to be repeated. And then what we'll do is we'll then run k-anonymity and see what happens. So as you can see here on the screen, what you have is, again, as I said, the same patient, patient ID 101010, has the same date of birth. It's not changing over time. That's the level 1 component. Gender is not changing over time. But the visit dates do, and the postal codes do. And then you run k-anonymity with a bit of generalization, and you find, well, there's some problems. Look at patient 11. Patient 11, their date of birth was suppressed. Their gender was suppressed. But that doesn't make any sense because, well, in that case, the whole record was removed. If there had still been a visit date, however, that would have been a problem because we'd still have their date of birth in the other records. And that's what you see if you look at the second line for patient 11. What you see is their postal code was removed. But isn't that just the same post? Did they actually move? And so there's things that aren't going to work here. It's going to suppress, it doesn't know, the algorithm doesn't recognize the fact that you have two levels of data. So we need to think about this a little bit differently. We need to reorganize the data, and this is why I kind of hinted at we're going to flatten the data. So we're going to take those multiple visits and we're going to push them across a single row. And we call this complete knowledge. We have two different approaches to that, but the idea is that we're going to do things a little differently. So again, we're going to have the exact same data set we had before. We're going to take that data and we're going to flatten it into two levels. I got to wait for the slides to catch up here. But the basic idea is you want to have one row for the patient. So it's the exact same data we had before, but we're going to flatten it. And then we're going to take those patients and we're going to look at the patients that only have one visit. And then we're going to de-identify them, for example, using k-anonymity. And we're going to look at the patients that have 3 visits. And now we're going to take them and we're going to run k-anonymity on them, for example. So what you've done is you've flattened the data so that we can use the same approach that we talked about before. And there's another way of doing this. You could also group the postal codes with the visit dates. That's just another form of complete knowledge that we describe in the book. But the idea, again, is just that you're flattening the data, but you're grouping terms now. That'll come up shortly on the slides. So now that we've discussed briefly these couple of approaches of complete knowledge and different ways to look at longitudinal data, let's look at a specific example. So we take the California database, the SID for California, and this time researcher Ronnie wants a public data set. Maybe he has students that he wants to present this data to. So he doesn't want to go through all the process of de-identification for every student. It's too much. So he just wants a public data set. So we come up with a data set. He asks us for example, gender, birth year, admission year when a person was admitted to hospital, their days since their last healthcare service, and a length of stay. The details here don't really matter. The point is that you have level 1 and level 2 data that are being requested. So we're going to go through the same process as before, but first I want to show you just what this data looks like, so the number of visits. So in this case, most people only have, in this particular cut of the data, they only have 1 visit. Some have 2, some have 3, but for the most part, there isn't a long trailing tail of people that have 200, 300 visits, as you might have if you were looking at, for example, the days in hospital or something, because you could have people that are in hospital for an entire year. So now when we look at measuring risk under these, our previous attacks that we saw before, it's the same scenarios, except now we go straight to public data. We don't have to worry about the deliberate attempt or the inadvertent attempt or the data breach. We only want to look at public data. And we're going to look at maximum risk, not average risk. So we're going to set a threshold of 0.09, similar to what we saw before, except researcher Ronnie was actually average risk. We don't really have time to discuss the differences here, but the point is that it's a different metric. And then we de-identify the data. So I'll quickly go through this. So you de-identify data, you're going to have birth year is going to be generalized to, say, a 5-year band. Admission year is going to remain unchanged in this case. The days since last service are going to be 28 days. This is just an example. It could be different generalizations. It depends on what you set as your parameters. And you get a certain amount of suppression, of course, which is what we show. But there's an important one here, and that's the length of stay and days since last service. They're the same, and there's a reason for that, and that's because we connected them. We call these connected variables. It's important that you not generalize 2 different fields that are related differently. You don't want one to be in days, the other one to be in weeks, or in this case, 28 days, so basically a month and a week. So you want to keep them connected together when you apply this generalization and suppression. So we call that quasi-identifier to quasi-identifier. These are indirect identifiers, QI to QI. They're similar, therefore we want to apply the same generalization and the same suppression. If you suppress one, you suppress the other, because otherwise you can infer one from the other, and that would be bad, of course. After that, we look at an extension of that, which we don't see in this data set, but what if you had a quasi-identifier that linked to something that wasn't a quasi-identifier, but in the same way could tell you what was in that? So for a perfect example would be a disease. If you had a column with a disease code, for example, asthma, then you don't want the description field to say asthma. So you have to delete both the code for asthma, maybe it's 1, 2, 3, and you need to suppress, obviously, that description as well. So there are other issues with longitudinal data, which we describe in the book. Don't really have time to discuss it here. So I think we'll just mention briefly that there are things like the truncation of records. There's date shifting to maintain the order. There is another assumption called adversary power that we use. And then there are things that aren't specific to longitudinal data, which I'm just scrolling through some of our slides here because I think we're going to skip some of it. So again, these are other chapters of the book where we talk about, for example, free-form text. We have to anonymize the text itself. There's a risk way to do that, a risk-based way to do it. There's geospatial information. We have more about that in there. Khaled mentioned aggregation. But there's also geoproxy risk we have to consider. For example, I always go to my pharmacist that's down the street. Therefore, if you give out pharmacy data, you're going to know my address as well, or at least my postal code. There are medical codes, and there's the concept of secure linking, which is encrypted linking of data sets, which we describe in the book as well, but we don't have time for that here. So what we'll do is, since that was a bit of a heavy section to some degree, we'll take some questions now.
All right, we have quite a few questions here. Let's see here. James would like to know who would want to access a database of health records, insurance companies, a government, law enforcement, other providers, or better yet, how would it break down?
I think all of the above. I mean, we mentioned demonstration attacks. These are real. There are cases of commercial entities essentially performing data linking, which amounts to de-identification. It amounts to re-identification. in order to enhance their data sets. So there are cases of those. So and then of course you have the as I mentioned, there's a whole discipline emerging of re-identification attackers, so folks who build a career on coming up with new ways to re-identify data sets. So I mean, these are examples of demonstration attacks as well. So yeah, all of the above. I mean, for criminals, so let me talk about criminal element. There's so the cost of a single record is generally not very high. So you know, if someone wants to monetize health databases for financial purposes, so for criminal purposes, it makes more sense to attack a whole database rather than individual single records, because single record is not worth much. But then the other argument is there are much easier ways to make money than re-identify a health database. So the strong motive is not necessarily there. But we discussed this issue in the book in terms of who are the likely attackers. But I think the examples mentioned in the question are all plausible ones. Not for nefarious reasons. I mean, the enhancing a database for marketing purposes may be legitimate, but if you don't identify your data set properly, then this essentially amounts to a re-identification attack.
Excellent. Brent would like to know, is storing in the cloud data set, whether it's cleaned up or in its original state, even an option?
Well, I mean, yeah, I mean, it depends. I mean, the cloud service provider, if this is personal health information, this is data that has not been de-identified, then let's say in the U.S., the cloud service provider may be considered as a business associate, which means that all the HIPAA obligations then would fall on top of on the cloud service provider, and these are some very serious obligations. If the cloud service provider is not willing to sign a BAA, a business associate agreement, and accept to be covered by HIPAA, then the data set has to be de-identified. Otherwise, there will be questionable authority to disclose that data to the cloud provider. So these are the things you would have to consider, whether the disclosure is covered by existing legislation or contractual arrangements. So in the U.S., the BA and the BAA issue would definitely come up as the main point to consider.
All right, and John would like to know, how do you quantify when abilities to re-identify only get better over time?
Quantify the ability. Well, our techniques get better over time as well, I would say. I mean, we keep improving on that. I'm assuming you mean by the question is asking about whether or not the techniques used to re-identify are getting better, as in like machine learning algorithms and whatnot. But there's a flip side to that, which is the techniques that we're developing to de-identify, for example. A perfect example is actually the text anonymization. These things just get better over time as well. So it's a give and take, I suppose. Yeah, the other thing is, I mean, you can apply this, if you apply the same logic to cryptography, methods to attack crypto systems are improving over time and weaknesses are being discovered. That doesn't mean you shouldn't encrypt your data now. You still encrypt, knowing that in a few years' time, machines will get faster, weaknesses may be discovered, etc. But that doesn't mean you don't take precautions now. You still protect your data now, you still encrypt, you still de-identify using the best methods available now, even though there's some risk that in the future, that data the risk may increase of re-identification or being able to attack the crypto system that was used.
And James would like to know, is there one preferred data schema for SQL and NoSQL databases?
No, I think the methods that are used will be specific to the data set. We see a lot of the heterogeneity of health data is quite significant. So I don't think there's any single general schema. I mean, there are certain techniques you would use that require the data to be converted to a particular structure. But again, that structure will be dependent on the techniques and the mix of techniques that you're using to de-identify your data.
All right, and David would like to know, where do the threshold figures come from and what do they mean?
There are probabilities of re-identification, and they come from precedents. So we did a review of precedents. The citations are, again, in the book. So there are many precedents over the last 20 years. You have judgments in courts, regulator orders, best practice guidelines, organizations, government organizations. in multiple jurisdictions releasing data using those thresholds. So there's a very strong precedent, and that's documented with, again, citations in the book where these precedents have come from. But they go back, a decade, 2 decades. Census Bureau. This stuff has been around for some time, right? So these are pretty well baked in precedents. So the issue is you have a range, and where do you draw the line within that range? What's the acceptable threshold you choose within that range that's defensible? But that range is a strong precedence for that.
All right, and just a few more questions here. Kristen would like to know if a pharmaceutical company creates a social media store for their clinical traits participants, are they still considered a covered entity, or is the site now like patients like me?
Well, I mean, the definition of covered entity is very specific. I don't know if I mean, it'll depend on the facts basically of the site that you're talking about. But I mean, one of the first questions if you're talking about HIPAA is, are you covered by HIPAA or not? And generally speaking, organizations that collect data directly from consumers would not be considered covered entities. But the facts do matter, so you need to talk to a lawyer about this. However, if you're not covered by HIPAA, there are other regulations that may apply. So the FTC, for example, may become the regulator that you need to be looking at. So if not being covered by HIPAA does not necessarily exclude you from coverage by any agency or any regulation.
And James would like to know, is there a third-party service which can transfer a patient's health data between unlike databases after the proper legal releases, of course, where the patient changes both medical provider and insurance carrier?
I think we'll answer what we think our interpretation is. I mean, one of the practical issues that you would need to address when you're trying to implement something like this is being able to link records that belong to the patient from multiple sources. So Luke mentioned secure linking, and this is covered in as a chapter, different techniques to use essentially homomorphic encryption to implement secure linking to allow you to connect patients from multiple sources without releasing any personal information. So that way, then you would this would not be covered, not be considered a disclosure of personal health information. But I mean, as a general statement, I think that there are good solutions to data sharing problems. So, but the specific solution to apply will depend on the case.
And Ricardo wants to know, are the questionnaires used to mitigate the probability standardized international standards?
They are mapped to, so we've developed some of these questionnaires and we've mapped them back to international standards. So we've mapped them to 27002, the ISO standard. We've mapped them to COBIT, GAP, the HIPAA security rule, the information security policies of the federal government. So they map back pretty much to all international and national standards. I mean, these are all publicly available as well as the mappings. They're not a surprise. What's covered is not a surprise. But what we have done is package it in a single checklist, a questionnaire that has face validity, has been used, has been validated, it's gone through a number of validations with privacy and security experts. So I would say it has strong, the checklist we use that's available has strong face validity, and we're seeing a few other organizations adopt it. But they map back to international standards. So there's a walkthrough from one to the other. There's no surprise that it pretty much covers the same types of issues you'd see in ISO 27002, for example, except that it's just a subset of that. So we call it the health subset. And the way this checklist was constructed was by going to organizations that share data and collecting the practices they require when they release data. So essentially, it's a union of contemporary best practices by these large data custodians who share a lot of health data. So it's the practical, contemporary subset of some of these international standards.
Great, thank you. And we just have 2 more questions here. David wants to know, where does K = 3 come from in K anonymous?
Well, k-anonymity has been around for about 20 years. It wasn't called k-anonymity then. It was called cell size, minimal cell size. So if you look at initial, really early releases of census data, this stuff has been around for many years. But the computer science community rebranded it as k-anonymity, so that's kind of the term that stuck. K equals 3 is...
just an example of what we were using.
Yeah, just an example.
You could, I mean, it's risk-based, so if you're doing just k-anonymity, then you would say, well, the risk is 1 over 3, so 33%. But that's just an example of where we wanted to start the process. There are more things. It gets more complicated, of course, but it's sort of the easiest one to understand because you just need 3 people to look the same, and then they're anonymous because, well, there's 3 of them, right? 1 over 3. But that was just an example.
All right, and last question here. What do you find is the biggest reason in practice that companies want to use for de-identification software? Is it to monetize the value of the data they hold, or is it out of concern for legal or regulatory problems if they don't de-identify?
It's both of those. So, I mean, the compliance issues are very serious because the consequences of not doing this properly can be quite costly for the organization. In terms of, breach notification costs, but also penalties. Enforcement is increasing significantly, and of course reputational harm, litigation. So the consequences of not doing the identification in a defensible way is becoming more serious. And then of course there are a lot of opportunities for monetizing the data as well. There are many business models that are emerging that use data sets to create information products or to enhance existing services, and so that data has a lot of value, and a lot of organizations are realizing this and trying to monetize their data. And I think this is a trend that will just keep on growing over time. So the issue is not whether this is happening or whether this should be done. I think the issue is how do you do it in a responsible way, and in a way that will be protective of the privacy of the data subjects, of these patients.
I would also add that a lot of the data sets that we're seeing and people that are coming to us are looking to do research, not necessarily, so it's a public health thing like BORN. They want to provide data to researchers, and so that's another reason they would want to de-identify, not just to monetize.
Excellent. Well, thank you, too, for a fabulous webcast. That was excellent. We had lots of engagement here with the audience, and great questions. Thank you very much, audience. Anything else you two would like to add before we end this event?
No, I think if you have any more questions, please send us an email. We have a lot more material that we can share and links that we can send you to if you have specific questions about techniques or examples or and of course, we strongly encourage you to go through the book. A lot of good case studies there that reflect quite a few years of experience and a lot of techniques as well that can result in high utility data being de-identified.
All right, everyone, that's it for today's webcast. Let's thank Khaled and Luke for their time and an excellent presentation. And as a reminder, we will have this webcast archive up within 48 hours. So thank you all for joining us today. We hope to have you in future webcasts. And again, a big thank you to you two gentlemen for a presentation today. Don't forget that Dr. Khaled is going to be speaking at our Strata RX conference in Boston, which is September 25th to the 27th. And he is speaking on Wednesday the 25th. So you could see him live if you'd like to and shake his hand. Again, thank you all. Have a good morning, evening, and night from wherever you are. This concludes the webcast. Goodbye.
Thank you very much.
Bye.